Good day everyone. In this presentation, we will be presenting the disease tuberculosis. This discussion is consisting of the etiology and pathogenesis, clinical features of the disease, how it is diagnosed and treated. So first, we have the etiology and pathogenesis of tuberculosis. Tuberculosis is a human disease that usually affects the lungs, but may also affect other organ systems such as the gastrointestinal or GI tract, the skin, the central nervous system, the musculoskeletal system, the lymphoreticular system, the reproductive system, and the liver. It is caused by the bacteria Mycobacterium tuberculosis and alcohol and acid-fast bacillus. It is non-spore-forming, non-motile, obligate aerobic, facultative, and catalase negative. Infection occurs through the inhalation of infected aerosolized droplets, which is dispersed through coughing, singing, or other forced respiratory processes. A person with cavitary lesions is especially infectious due to the high amount of bacteria present. Moreover, transmission is enhanced by frequent or prolonged exposure to untreated patients, especially. Tuberculosis occurs in 3 stages: primary infection, latent infection, then active infection. Primary infection requires the inhalation of particles small enough to travel to and penetrate the upper respiratory defenses, and then deposit into the subpleural air spaces of the middle or lower lobes. These particles arise from a single droplet nucleus that carries Mycobacterium tuberculosis particles. The organisms replicate for 2 to 12 weeks until they reach 1,000 to 10,000 in number, which will then be enough to induce a cellular immune response. Mycobacteria are highly antigenic, and they promote a vigorous, nonspecific immune response. Their antigenicity is due to multiple cell wall constituents, including glycoproteins, phospholipids, and WAX-D, which activate longer lymphocytes and polymorphonuclear leukocytes. In the early weeks of infection, some infected macrophages travel to regional lymph nodes, where they can penetrate the bloodstream. Organisms may then spread to any part of the body through the blood, particularly the apical posterior portion of the lungs, as of the lung bones, kidneys, vertebral bodies, and meninges. After approximately 3 weeks of growth, the infection may be suppressed into an inactive form called latent tuberculosis infection, or LTBI, with resistant hosts controlling mycobacterial growth at distant foci before symptoms or signs develop. Foci of bacilli in the lung or other sites resolve into epithelioid cell granulomas, which may have caseous and necrotic centers. Tubercle bacilli can survive in this material for years. The balance between the host resistance and microbial virulence determines whether the infection ultimately resolves without treatment, remains dormant, or becomes active. If cellular immunity is impaired, this can facilitate the reactivation of infection in any organ with latent infection. However, reactivation most often occurs in the lungs due to favorable local conditions such as high oxygen tension. In some, though, active tuberculosis develops through reinfection rather than reactivation. Next, we're gonna discuss the clinical features of the disease. Tuberculosis is divided into 2 pathophysiologic types, being primary and secondary. Primary tuberculosis occurs in a person who is unsensitized or has not been exposed to the infection with Mycobacterium tuberculosis. and thus it is understood that the microorganism involved is from an exogenous source. Primary TB will initially present with mild flu-like to no symptoms. Secondary tuberculosis, on the other hand, occurs in a previously sensitized host. It can follow shortly after primary tuberculosis or may become latent and arise years after, especially when host resistance is weakened or compromised. General manifestations of active tuberculosis often include remittent fever, night sweats, malaise, loss of appetite, and weight loss. More specifically, with pulmonary TB, there is persistent cough. Purulent sputum appears and diuretic pain occurs with progressive pulmonary involvement, while hemoptysis, when the patient coughs up blood, is present in about half of all cases of pulmonary tuberculosis. Now, let us go to the diagnosis of the disease. In the general diagnostic approach, the diagnosis of pulmonary tuberculosis should be suspected in patients with relevant clinical manifestations, such as cough of less than 2 to 3 weeks duration, lymphadenopathy, fevers, night sweats, weight loss, and relevant epidemiologic factors such as history of prior TB infection or disease, known or possible TB exposure, and/or past or present residence or travel to an area where TB is endemic. Patients being evaluated for pulmonary tuberculosis who pose a public health risk for transmission should be admitted and isolated with airborne precautions. The diagnosis of pulmonary tuberculosis is definitively established by isolation of Mycobacterium tuberculosis from a bodily secretion, such as culture of sputum, bronchoalveolar lavage, or pleural fluid, or tissue, such as pleural biopsy or lung biopsy. Additional diagnostic tools include sputum acid fast bacilli, or AFB smear, and nucleic acid amplification, or NAA testing. Positive NAA test with or without AFB smear positivity is considered sufficient for diagnosis of tuberculosis. Radiographic studies are important supportive diagnostic tools. The approach to diagnosis of tuberculosis begins with a history and physical examination to assess the patient's risk for TB. Patients meeting clinical criteria should undergo chest radiography if imaging suggests TB of the lungs or airways. 3 sputum specimens obtained via cough or induction at least 8 hours apart and including at least 1 early morning specimen should be submitted for AFB smear, mycobacterial culture, and NAA testing. In addition, a tuberculin skin test or TST or interferon gamma release assay or IGRA should be performed. These are tools designed for diagnosis of TB infection. A positive result supports but cannot be used to establish a diagnosis of active TB disease, and a negative result does not rule out active TB disease. In HIV-infected patients with CD4 counts of less than 100 cells per cubic millimeter, mycobacterial cultures of blood and urine should also be performed. Lastly, we have the treatment of the disease. The primary treatment course for tuberculosis involves antibiotics medication for several months. Proper adherence to the prescribed treatment protocol for months is highly essential to ensure the elimination of the TB bacteria and to prevent drug resistance of the TB infection. TB medication are categorized as first-line drugs, second-line drugs, and third-line drugs. The 4 main drugs forming the initial or first-line treatment regimen for TB are isoniazid, rifampicin, ethambutol, and pyrazinamide. Rifabutin and rifapentine are also used as first-line anti-tuberculosis or anti-TB drugs. TB can be treated effectively by using these first-line drugs. However, if the first line of therapy fails, such as due to the emergence of multi-drug resistant TB strains, the application of second-line drugs is required. For the second-line drugs, there are 3 subgroups and some of the example drugs are listed on the table. There are injectable anti-TB drugs such as kanamycin and amikacin, fluoroquinolones like levofloxacin and ciprofloxacin, which have broad-spectrum antimicrobial activity, and other second-line anti-TB drugs such as ethionamide, prothionamide, and cycloserine. Under third-line drugs are these medications with variable but unproven efficacy against TB. These drugs are typically used as a last resort for total drug-resistant TB. The treatment phase for tuberculosis mainly consists of the initial phase and the continuation phase. In the initial phase, most of the tubercle bacilli are killed, and one of the key goals is to prevent drug resistance. This phase determines the ultimate outcome of the treatment regimen, and it usually involves a 4-drug treatment course of isoniazid, rifampicin, ethambutol, and pyrazinamide for over 2 months. The continuation phase takes either 4 or 7 months depending on the status of the patient, and its purpose is to kill the remaining tubercle bacilli that may have survived the initial phase. Overall, the treatment duration and completion are dependent on the drugs used, drug susceptibility, test results of the isolate, and the patient's response to therapy. Monthly monitoring of sputum smears and cultures throughout treatment is essential for timely detection of conversion or failure to convert, which has major implications on the clinical management of TB. Signs of treatment failure, such as persistence of symptoms associated with TB or the emergence of multi-drug resistance in the treatment duration, require a change in the regimen. Sputum smears, culture, and acid fast stains remain relevant for treatment monitoring. With sputum cultures, a sample of sputum is placed onto a nutrient-rich medium to encourage the growth of microorganisms responsible for a specific infection, which are then identified through staining. In sputum smear, collected sputum samples are evenly spread on slides and placed in a fixative for staining. Acid-fast staining methods use a technique where the microbacteria retain a primary stain after exposure to decolorizing acid alcohol. 2 common methods used for staining mycobacteria are the Ziehl-Neelsen staining and the aramine-rhodamine fluorescent technique. Between the two, the more rapid and most sensitive method for mycobacteria is the aramine-rhodamine stain, which requires a fluorescence microscope for viewing. That is all for today's discussion. Thank you and good day again.